Good morning, everyone. I think everyone here knows who I am. I'm Greg Basil. I'm one of the PGY6s here. And today I'm going to be talking to you about metals in spine surgery. Now I think every good talk should have an inspiration. We shouldn't just be talking about things for the sake of talking about them. I'm not saying this is a good talk. You guys could tell me that at the end, but it does have inspiration. And the inspiration is our very own Dr. Michael Wang. And this is a quote. Dr. Wang said this quote to me in the operating room. He said, "You guys literally know nothing about metals, seriously. Go and spend some time with your orthopedic colleagues and they can teach you a thing or two." Now, I think when Dr. Wang said this to me, I was a little bit defensive. I disagreed with him, but I went home and I thought about it a little bit and I realized he was right. We don't really know a whole lot about the metals we're putting into patients' bodies. I think we think a lot about anatomy, physiology, surgical approaches. We learn how to put grafts in, but we don't, I think, spend enough time thinking about what we're actually putting in. And so, as I thought about this, I tried to summarize what I believe to be the resident kind of collective knowledge about metals. And I know some of you may virtually raise your hands and say, "Greg, no, we know more about metals than you're putting here on the slide." And that may be true, but I think on average this is pretty accurate. So titanium, that's what we use for screws. Cobalt Chrome, that's what we use when we need a strong rod. Stress strain causes hardware to break. Infections are bad, take out the hardware. Imaging, metal creates artifact. Biocompatibility, screws are inert. Cold welding, no idea, or something Dr. Wang talks about when set screws get stuck. So I think this just speaks to the fact that we're not really thinking critically enough about the implants that we're placing in our patients' bodies. And I think in many cases, our thinking isn't much more complex than what kind of rod we're going to use. And we don't even really think about stainless steel. So it's really either titanium, which is most of the time. And occasionally, if we have a rod breakage, someone may bring up the idea of cobalt-chromium or cobalt chrome. Terms are synonymous. And so, as I began to think about this, I found this paper talking about metals in spine surgery, and I really like this quote. And the author says, "Just as it is important for a sculptor to choose and understand the stone to create a perfect statue, so does a deformity surgeon in selecting appropriate implant metal for a corrective measure." Now, I know at this point, many of you are hearing this talk and saying, well, Greg, why are we just talking about metals? We put a lot of different substances in the patient's bodies, not just metals. What about PEEK? What about polymers? What about ceramics? And sure, those are all important things, but I have a good reason why I'm just talking about metals today. First, metals are the most commonly used implants, and they're becoming even more pervasive. Second, they require complex and detailed discussion, and you can see I have over 100 slides here just scratching the surface of a discussion of metals. Third, I think if you understand metals, you'll have a matrix to evaluate other materials. And finally, they're a common source of concern and topic of discussion amongst patients. And so, I think most of you know I have a new child, my first kid. Her name is Sophie. She's about 9 weeks old now. And so I'm starting to begin to think about, how I'm going to teach her some basic concepts, colors, shapes, hot, cold. So I think much in the same way with this particular topic, we need to start basic. And so I'll provide some definitions, and then we'll move on to the more interesting stuff, which is the clinical application. And so first is biofunctionality. And that just refers to the mechanical properties of alloys as it pertains to fulfilling the required job function. And so in the case of spine surgery in general, and there's a lot more nuance in this, it's high strength, stiffness, and fatigue resistance. Then there's this concept of biocompatibility, and that refers to the presence or absence of an alloy's interaction with the internal environment of the human. So in other words, truly biocompatible substances are inert. They do not produce negative responses, no toxic response, no immunologic response when they're exposed to body tissues. And then finally, biomechanics. And I put up a definition here, which is a study of mechanical laws relating to the movement or structure of living organisms. And, a lot of what we're going to talk about today is biomechanics, because it's incredibly important. And the major properties that we're going to talk about, and there's a lot of different biomechanical properties, but the ones we're really going to talk about are fatigue, elasticity, and stress and strain. And so we'll move into that. And we'll start with fatigue. And I started with fatigue for a reason. I think it's probably one of the most important characteristics to think about when we think about spine surgery. And, I've put a picture of a cracked metal here, but in very simple terms, fatigue refers to how long an implant will last before breaking. And so you could think about that fatigue process as, a material has repetitive stresses placed upon it, cracks form, those cracks grow to a critical size, and ultimately a fracture occurs. But how do we determine fatigue? Well, fatigue is basically a measure of resistance to cyclic loading. And so in order to determine fatigue and fatigue resistance, we need to cyclically load a material. And so I've put an illustration up here, which is a picture of a rod. So basically, you apply constant bending stress to a cylindrical sample of the material, and you rotate it about that stress axis, and you count the number of rotations until it breaks. And so you do that repetitively for a large number of cycles, and then you can determine the expected number of cycles to failure at a given stress. And then they run all these different tests. You can run subsequent tests at lower cyclic stress values until you find the stress at which a sample will survive 10 million cycles, and that's referred to as endurance limit. Why am I putting that term here? This is a term that's used pretty commonly in the literature if you start to read about this, so the terminology becomes a little bit important for you to understand what people are talking about. And then there's this concept of ultimate tensile strength, which is the maximum stress a material can stand before breaking. So in general, that endurance limit, where it can withstand 10 million cycles, is about 40 to 50% of upper tensile strength. But that testing I'm describing is obviously in vitro, not in vivo testing. And it doesn't really simulate the true environment in vivo, right? In vivo, you're gonna have all different stresses along different axes that vary over time. But they are useful as a benchmark to understand relative strength. So that's how we can begin to use them to understand the relative strengths of material. The next concept is elasticity, and that's the ability of the metal to deform and then revert back to its original shape. And that's defined by the Young's modulus of elasticity, which I've included a diagram of here. But basically, elasticity can also be thought of as the stiffness of a solid material. And that's determined by the relationship between stress and strain. Stress, of course, is force per unit area, and strain is basically proportional deformation. In other words, how many inches of deformation in a material per inch of material length. And so Young's modulus is this stress over strain in this what's called the elastic deformation zone. So at small stresses, deformation is elastic. In other words, it's reversible. And you see that in the linear portion of this graph. But past a certain stress level, which we call the yield strength, the material will undergo permanent deformation. In other words, if you bend a rod past a certain point, it's not just going to, if you stretch it past a certain point, it's not just going to bounce back to its original shape. It's going to be permanently bent. And we see that all the time. So how do you interpret that? And again, I'm really simplifying these concepts so we can understand them. Obviously, this is kind of, you could talk about this one topic for a long time on its own. But the higher the Young's modulus, the more stress is needed to create the same amount of strain. So a perfectly rigid body would have an infinitely high Young's modulus, and a very soft material like a fluid would deform without any stress at all, and would therefore have essentially a zero Young's modulus. And so just to summarize this one more time, because we're going to talk about it in clinical applications again, Young's modulus is a measure of stiffness. A high Young's modulus is a stiffer material, lower is a more elastic, less stiff material. And so once you understand that, you can begin to define terms like strength. We talk about things being strong all the time, but what does strength really mean? Well, in this context, we can define it as the maximum amount of stress a material can withstand while staying in that reversible deformation zone. And then we can define this other term, ultimate strength, as the amount of stress that pushes materials from the state of uniform deformation to local concentrated deformation and breakage. In other words, once they go past that point, they will break at some point unpredictably. I said I was going to talk about definitions before I get to clinical application, but for this next one, you have to talk about them together because it really only applies to spine surgery. So this concept is notch effect. And many of you, the picture I've put up here, you guys are all familiar with, but this occurs when we bend rods for implementation and we create these small or maybe not so small notches in the rods. And that happens via French benders. And the problem is that these notches that we place in the rods actually alter the rod's fatigue resistance. And that's described by the term notch sensitivity, and this overall phenomenon of fatigue resistance being decreased via notches is referred to as notch effect. This is not just like a theoretical construct. It's been well described in the literature. I'm going to show you a lot of studies today, so we're not going to spend a ton of time on each one. You guys, I'm happy to send this along to you and reference it, but this is a biomechanical study. And basically they want to quantify this notch effect. And so obviously they can't use cadaveric bone to do this because you can't control for the density of the bone and the different anatomies. So basically, they create these polyethylene blocks to simulate vertebral bodies. They tap them with polyaxial screws, and they use 4 different rod materials: titanium alloy, commercially pure titanium steel, and stainless steel. And they mount them for stress testing, and they cycle them at a load ratio of 10. That just means that's a ratio of min to max load. I didn't put up exactly what the loads were here. It's not really important to understand the results. But what did they find? Basically, they found significant differences in fatigue life between the contoured titanium and contoured stainless steel constructs, with stainless steel having a higher fatigue resistance, and significant difference for the contoured titanium rod versus straight rod, and contoured commercially pure titanium rod versus straight. In other words, the contouring of the rods significantly decreased the fatigue resistance. And I think the number is about 60% reduction. It's quite significant. Additionally, all the titanium rods failed at the bend site, whereas the straight rods failed at the rod screw interface. So they failed at a higher stress and at the rod screw interface. So the ultimate conclusion here was that intraoperative contouring significantly reduces the fatigue life of titanium rods. And this is just a picture that demonstrates this is a contoured rod. You see it broke at the site of notching, and the straight rod broke at the rod screw interface. So, you see this, you can begin to understand now when you see cases of pseudoarthrosis or instrumentation breakage. I think we need to not only think about what the next surgery is, but why it happened. And sometimes just understanding the pattern of breakage can help you understand that. The other thing is that, I think we're constantly being inundated with new products from industry, and we have a lot of choices in the operating room. And we need to start understanding why people are doing different things. For example, contoured rods. Yes, they make the surgeon's life easier, and that's a kind of a simplistic understanding of why we might use contoured rods. But the real reason the contoured rods are valuable is for this reason, because of notch effect. And it's particularly pronounced in titanium and mostly described in reference to titanium. And I just put this up here. This is an article talking about how this Medicrate group now creates these custom pre-bent rods, pre-contoured rods for patients. And this kind of explains why that may be valuable. The next topic we're going to speak on is corrosion. And, I think everybody, fundamentally understands what corrosion is. And I think most people probably think it doesn't apply to the metal that we put in our patients. Patients always ask us, will the metal rust? No, the metal won't rust, but does corrosion occur? It does. And so, I'm going to talk about 3 types of corrosion. There's actually like 8 types of corrosion. 5 of them are commonly discussed outside of this context, but in reference to spinal surgery and instrumentation, really 3 that are commonly described in the literature. The first is fretting, which is basically a mechanical corrosion, and that occurs due to oscillatory slip between 2 surfaces. There's crevice corrosion, which is exactly what it sounds like. It occurs at crevice sites. And so basically, when you have an area that's shielded from full exposure to the environment due to close proximity between 2 metal surfaces, so for example, a rod that's linked into a screw, the crevices allow oxygenated fluids to percolate, and it causes corrosion due to varying oxygen tensions and pH levels. And then finally, there's galvanic corrosion, which is basically when there's 2 metals in close contact in a corrosive environment, basically an electric or galvanic circuit is created, and that can cause corrosion on its own. Obviously the end effect of corrosion, and we're going to talk about it again in clinical applications shortly, can be multiple: implant damage, tissue damage, health sequelae, and we would ideally have 0 corrosion in the internal environment of the body. The reality is that different metals have different corrosion, and potentially, and we'll talk about that as well, mixing metals may accelerate that corrosive process. Titanium alloys that we use most of the time are protected from corrosion with a coating. It's this titanium oxide layer. But again, that layer is about 4 to 6 nanometers thick. So again, when we manipulate rods, if there's a pseudoarthrosis and those rods are rubbing and that coating gets rubbed off, the potential for corrosion certainly exists. So that's kind of the basic definition stuff, and we can get on to the more interesting stuff, which is clinical applications. So, we described this modulus of elasticity, and, we're talking about it in context of metals, but it's actually a lot more complicated than that, right? You can't just think about the metal, you need to think about the application. So for example, there's been some literature to suggest that interbody implants should be chosen to have a modulus of elasticity most like that of surrounding bone. Likewise, there's literature to suggest that rods, if they have a higher modulus of elasticity, will aid in fusion, but at the same time, higher modulus of elasticity may lead to other complications like PJK and things like that. So let's get into that a little bit. So this is a study that's talking about modulus of elasticity in the selection of inner body implants. And basically, they have these multiple uniformly cube-shaped implants made of titanium, titanium alloy, cobalt chrome, stainless steel PEEK, and carbon fiber reinforced PEEK. And they test them under cyclic compressive forces. And, these are basically the results. And, I'll make them, overarching point of what the study's talking about, which is what you can see here is that all of the metals, whether it's stainless steel, titanium, or cobalt chrome, have a very, very different elastic modulus than either cortical or cancellous bone, which you see all the way to the left here in these graphs. And you see the same thing in the stress strain curves, which we now know is equivalent to this. That's how we calculate our modulus of elasticity. Again, if you go all the way over to the right, you see PEEK, and then you see the big difference between titanium, stainless steel, and normal cortical bone. And so what did they conclude from that study? They basically said that this mismatch between elastic modulus of bone and metal implants may lead to increased rate of subsidence. Obviously, they didn't specifically test that, but they did prove the difference. And so, a lot of you, are familiar with these porous titanium grafts. They're becoming increasingly prevalent. And question is, why are they becoming increasingly prevalent? And do they potentially deal with this issue of mismatched modulus of elasticity? So this is a study that was done in this Journal of Mechanical Behavior of Biomedical Materials. And it's a very, it's kind of a complicated study. If you really want to understand this very well, I recommend you book Ian Cahigas for an hour. But you guys understand the background of why they're doing the study. They're trying to see if you can architect a titanium graft to more closely match the modulus of elasticity of the bone. And so, it's a relatively complex study, but they use finite element analysis, which is basically a simulation. And so they take a CT scan, they reconstruct a functional spinal unit, they assign it material properties, and they use that to basically tune a titanium graft to optimize its graft construction and topology to match bone quality. And then they do this finite element analysis to compare it to this all titanium graft. And what they found was that there was likely a reduced risk of subsidence for the optimized implant versus fully solid. In other words, they were able to engineer the titanium graft to more closely match the modulus of elasticity of bone. And I've put here the number that they saw a 14% decrease in average stress on these components of the vertebral body. They used a C7, a simulated C7 vertebral body, and a more favorable distribution. But the porous titanium is obviously more complex than just elasticity. That's actually a huge component of it, because solid titanium grafts are not very favorable, given a huge mismatch and would lead to increased subsidence. But another component is that they can be made bioactive, and we'll talk about that in this particular study. But basically, they talk about this concept that porous grafts in general are very favorable because of osteoconductive bonding, right? It serves as a scaffolding for bone to grow. But the problem is that, what we were using traditionally for porous, for implants like PEEK, they're just not strong enough. If you make them porous, they're just going to break, right? So porous titanium offered a solution. And what these authors say is that if you combine that with a bioactive surface, in other words, a surface that has not just osteoconductive properties, but osteoinductive properties, that you're really optimizing your graft. And so what they did is they created these bioactive porous titanium grafts. I put a picture here from the study. They have about 60% porosity, 99% pore interconnectivity, which apparently is important for bony formation. And they treated them to make them bioactive, and it's basically a chemical processing of the graft. And they confirmed that they truly were bioactive by doing in vitro studies in an acellular simulated body fluid. And then they actually put these grafts in 5 patients with unstable lumbar fusion, and they did a clinical and radiologic assessment. And basically all patients had symptomatic relief. They had evidence of bony ingrowth after 3 months and fusion by 6 months. And they showed this, one patient who had, a reasonable gap between these, the inferior aspect of this end plate here and the graft. And they showed that graft filled in after 6 months. So their conclusion was that this porous bioactive titanium had significant promise. It almost perfectly matched the modulus of elasticity of bone. And by making it bioactive, and by the nature of it being porous, it had both osteoconductive and osteoinductive properties. So that's kind of how you can start to begin to think about metals in terms of interbody devices. In terms of screws, it's kind of equally complex. So this is a review of the literature that I've put here. And basically the premise here is, the question is, are rigid rods really superior? And there's multiple studies which demonstrate the fact that rigid rod fixation has improved rate of arthrodesis. Now, those studies are not referring to the relative rigidity. They're just saying putting rods and screws versus onlay fusion. But there are also studies that show a higher rate of fusion, and I'll show you a couple with rigid rods. But at the same time, there's problems with these stiff rods. So they have reduced load sharing through the bypass vertebral body. That can lead to reduced strain in the bone, which can lead to bone mineral loss. And obviously, rigid instrumentation imposes more stress on adjacent levels, which can lead to adjacent level disease. So, obviously, people want to find solutions to this. So they've proposed things like semi-rigid or memory rods. This study is a study that's talking about the issues with rods that are overly stiff. They're comparing cobalt chrome and titanium rods. And, obviously, and we'll talk about this a little bit later, cobalt chrome rods have increased strength and fatigue resistance. And so, they want to understand, whether or not that actually does lead to increased BJK. So this is a retrospective review. All these patients had 2-year follow-up, and they basically matched 50 patients with titanium rods to 50 patients with cobalt chrome rods. And they used x-rays, and if there was evidence of a pseudoarthrosis, a rod breakage, then they went and looked at the CT scans. And here's basically the summary of the results here. This is kind of all you need to know about this study. There was a higher rate of fusion with cobalt chrome. There was a lower rate of rod breakage, but there was a higher rate of PJK. So clearly that is a factor to consider. And this is another article, an opinion piece on flexible rods and a case for dynamic stabilization. And again, I think once you begin to understand these concepts, you begin to understand why people are pursuing things like dynamic stabilization. This particular author has talked about how when there was onlay fusion, you didn't have these issues of adjacent level disease. And he actually is suggesting something else. He's saying, well, what you need is a rod that has an intermediate stiffness. So is it stiff enough to promote fusion, but not so stiff as to cause adjacent level disease? And so that's, I think some people are aware that peak rods have been used in the past. This was really the reason why people were thinking about peak rods. I'm not going to get into peak rods. It's not a talk about peak rods and what was good and what was bad about them, but you can begin to understand why they were considered and why people are considering constructs like this. This is an interesting one where they were using a rigid rod below at the worst level of pathology, and then a semi-rigid construct above. But obviously every solution has its own problems. In this particular study, 15% of them had to have their dynamic stabilization converted to a rigid fusion, and actually 31% of them had subsequent spine surgery. So, if you're confused at this point about what the right answer is in terms of stiffness of rod, that's good. It means you're starting to understand the problem here and why there are so many potential solutions. So now that we've understood the clinical application of Young's modulus, we can go on to this concept of corrosion. So, I defined corrosion for you guys. I talked to you about the 3 different types of corrosion. And I think the question, many people have, is corrosion real, and is it relevant in what we do? And of course, people believe corrosion is real, in life, but in spine surgery, it's not something we really talk about. And so this particular study that I'm showing you here, they put the context of how many spinal fusions are performed annually. Obviously, this is an older paper; it's even more than that now. And obviously, there's an increasing number of metal implants being used, as I mentioned earlier. So they want to understand the magnitude. And so basically, they removed 49 thoracolumbar constructs, from patients, and they subjected them to gross inspection and microscopic examination. And they had a bunch of people look at them: material science engineers, orthopedic spine surgeons, and they looked for types of corrosion and whether there were fractured components, and they examined those fractured components. And this is basically what they found. The summary of these results is that stainless steel had a significant amount of corrosion. Matte stainless steel had more corrosion than polished stainless steel. Titanium had a small amount of corrosion, and Vitalium which we're not going to talk a whole lot about. It's not used a ton in our field. It's used more in dentistry and sometimes in pediatric cases. It's something similar to Cobalt Chrome, really had no corrosion. And you know, the more interesting finding about this, because it's kind of well known that stainless steel has more corrosion than titanium, was that the finish of the stainless steel seemed to contribute to that. And the reason that they hypothesized is that those different surfaces, so the screw being polished and the rod being matte, created more friction, and that led to more corrosion. I think, you know, that's also something to think about. We often get rods, and you'll see the finishes on the rods are some like beautiful, like whatever, if it's invasive, they might have some beautiful purple rods with, you know, a matte finish on them. Whether or not that matte finish actually contributes negatively to corrosion is something to be considered. Then there's this concept of galvanic corrosion, and when I first started reading about this, it didn't seem like something that was could be that significant. You know, that there could be some kind of electric circuit as a result of metals in close contact. But this is an interesting study where they look at that. And so, you know, they talk about this idea that there's a lot of literature on metal ion release in spine surgery that can cause a negative cellular response and inflammation and fibrosis, and that's true. And I'm not going to show a lot of that literature today because there's just too much ground to cover, and it's pretty much self-evident that would occur. But they wanted to more closely look at this concept of galvanic corrosion, which basically occurs when, you know, materials of different electrochemical properties are in close proximity, as we described earlier. And their theory was that that galvanic circuit could lead to osteolysis, which obviously would be a bad thing in a fusion patient. And so this was their hypothesis, that the loss of electrons due to periprosthetic corrosion could generate electric and electromagnetic phenomenon causing osteolysis. And, you know, the caveat is this is a really small study, and, you know, it's hard to generalize these results, but it's interesting. So they basically looked at 6 patients who had periprosthetic bone loss, right? Because if they don't have periprosthetic bone loss, then probably they weren't having osteolysis. And only one of those patients had their hardware explanted. So they're able to study that explanted hardware, look at for evidence of corrosion, and then see if it could actually generate a galvanic circuit. And then they separately prepared osteoblastic cell cultures, which they then exposed to the EMF current that was actually produced by this hardware. And so first off, they did find evidence of macroscopic evidence of corrosion. A lot of the corrosion was fretting that you can see here, which is a mechanical corrosion. And they did find a current, and I've put the current here. And obviously the current was created because the rod itself was commercially pure titanium and the screw was titanium alloy, so there was some electrochemical difference. And what they found was that when they exposed those osteoblast cell cultures to this current for different periods of time, and I've shown you the time periods here, 48, 72, 7 days, and 14 days, there was a significant decrease in osteoblast proliferation. And that effect increased with increased time from exposure. So again, you know, hard to extrapolate these results to every patient. And, you know, I don't think galvanic corrosion is going to be in the front and center of our mind in surgical planning, but it is a factor to consider. And people talk about it most when you think about mixing and matching metals, and we will talk about that in a little bit as well. So, you know, in addition to potentially affecting the bone locally in the area where the hardware is implanted, and the hardware itself, you know, the question is, can corrosion have systemic implications? And you know, this is a systematic review of metal ion concentrations following instrumented spinal fusion. And again, the background of this study is now understood by you guys pretty well. You know, the real question here is if metallic ions are absorbed into the bloodstream, and what are the long-term effects of that phenomenon? There's a lot of literature. Again, Dr. Wang wasn't wrong. The ortho guys definitely talk a lot more about metals than we do. There's a lot of literature in the orthopedic side of things where they talk about metal ion exposure in joints. And obviously joints, they're movable, so that this is going to be a more pronounced effect. But here's a systematic review they performed. This is their Prisma diagram. They ultimately included 18 studies in this particular study. And here's what they found. So the first thing is that there's not a lot of good literature on this. So most of the literature that does exist focused on stainless steel and titanium, but a lot of literature is retrospective. Sample sizes are quite small and patient populations are quite varied. There's also non-standardized methodologies for analyzing metal concentrations, and that makes the cross-study comparison quite difficult. Additionally, there's a high variability in terms of their attempt to correlate the metal levels with radiographic evidence of corrosion. Having said all that, there were some interesting things, and mainly that they observed that there were elevated levels of chromium and titanium ions postoperatively after stainless steel and titanium fusion. And that was particularly true in the plasma. There's also this time-dependent relationship, which I think is kind of self-evident, but basically you see this bell-shaped curve. So you see a rise in the ion levels immediately, after surgery, which makes sense, right? Because we've been manipulating that hardware in the body, and over time, those levels seem to fall, and they call that the wearing-in phenomenon. But when you think about that bell-shaped distribution, it is interesting to think about what it would mean if you don't see that. In other words, if the ion levels fall and then begin to rise, or never fall. And so, again, the orthopedic guys do look at this, and they've used metal ions as predictors or biomarkers of failure in hip arthroplasty. And this particular author suggests that we should be doing the same thing for spine surgery. What they don't do in this paper is specifically examine the impact of the mixed metals on this effect, and whether or not mixing titanium with stainless steel potentially could make this effect even more dramatic. And in terms of systemic effects, I think they're still relatively poorly understood. Even at the levels that we're talking about, they're quite low levels in the blood, but they suggest that maybe there could be reproductive issues of fetal development, poor quality of life, and risk of cancer. I'm not going to stand behind those particular claims, but it is something that we should at least understand. And I could tell you that for sure the orthopedists are taking this seriously. Again, slightly different because a lot of their surgery involves mobile metal on metal. But in this particular set of guidelines, which is the European Multidisciplinary Consensus Statement for total hip replacement and resurfacing, they measure that they state that as a routine part of follow-up in these patients, they should have x-rays, metal ion measurements of cobalt in the whole blood, and they actually suggest what levels are safe and what levels should be of concern. Okay, so that's the topic of corrosion. The next topic, which we obviously need to talk about, is infection. I'd say it's not uncommon for us to get consults on patients who have active infections, who many of them who have instability as a result, may or may not need instrumentation. And so, how do we begin to look at that in the context of the metals that we choose? And so, the main topic of discussion here is biofilm formation. And to take a step back, what is a biofilm? Well, a biofilm occurs when bacteria bind to implanted hardware and form this thick, resistant coating. And in general, the formation of biofilm necessitates hardware explantation. And I think the important thing that we can begin to understand is that biofilm formation isn't only influenced by bacteria type, by implant material as well. This is just a basic diagram of how biofilm forms. There's some bacterial cells that attach to the implant. They form this extracellular polymeric substance, which basically gives the biofilm structure. It proliferates, and then bacteria detaches and forms elsewhere, and the biofilm grows and gets bigger. And so, I've included a study here from the Journal of Clinical Neuroscience, which compares Staph aureus biofilm on cobalt chrome and titanium alloys. There's also studies looking at stainless steel. I didn't include them because that's one, there's just a lot to present here, but it's pretty well established that stainless steel has a higher rate of biofilm formation. And so in this particular study, they took 12 well plates for each alloy, so 24 total, obviously uniform diameter. They autoclaved them. They then had these Staph aureus cultures, which they incubated, and they added an equal amount to each of the well plates. And then they looked at optical density values of bacterial isolates and number of colony forming units to compare the titanium to the cobalt chrome. And basically what they found was that titanium outperforms cobalt chrome. This is optical density values. This is colony forming unit values. And so titanium seems to have a lower rate of biofilm formation than cobalt chrome, and certainly a lower biofilm formation than stainless steel. In terms of why that is, these authors didn't provide a direct explanation for why titanium seemed to have a lower rate of biofilm formation. but they do reference multiple orthopedic studies that talk about this, and they basically state that there's a number of factors that are important to consider in terms of propensity for biofilm formation, including surface roughness, hydrophobicity, and surface free radicals. So certainly, and I didn't find any studies on this specifically, but you can imagine, again, talking about texture of implant, that would influence biofilm formation.
Hey, Greg, is this really clinically relevant? I mean, we know that if you get an infection, clinical infection, deep infection with instrumentation, if you treat it acute and early, you do not need to remove the implants. I mean, I think that's the important message. Whether
Right.
the small biofilm residual difference between two different metals, it's clinically unimportant. It's a totally different concept than if you get an infection with a shunt, where you know that you'll never get rid of the infection.
Right.
You take out the
right, and I'm going to talk a little bit about that now and how it actually is safe to put metals in infections. But I think it's more just a matrix of evaluating the various metals. Would it be clinically relevant to begin thinking about when you're putting hardware in an active infection, which metal to use? I do think that may be clinically relevant, and certainly people are choosing titanium over stainless steel for that reason in infections.
Yeah, I mean, I don't think anybody uses stainless steel.
Not anymore, but there's a good reason, and that's one of the large reasons why. Can we place metal during active infection? That's what Dr. Levy is talking about. This is a particular study on the use of titanium mesh cages in a reconstruction of anterior column defects in active spinal infections. I actually just really like the title of this one, Can We Rest the Crest? Basically, they talk about how iliac crest autograft has been the mainstay of grafting material during active infections. And actually, I think Dr. Levy in conference was actually talking about how people are now using, or there's at least been one or two publications on using autograft with a vascular pedicle. But these authors note that obviously there's shortcomings of autograft, that sometimes there can be inadequate donor material for large defects. There can be donor site morbidity, chronic donor site pain. Given the increasing prevalence of titanium grafts, obviously people are beginning to think about using those for active infections. Obviously there's concern about biofilm formation, so that's why the study is being done. This study was a retrospective study. They had 70 patients. The caveat here is most of these patients had tuberculous osteomyelitis, not pyogenic, but there were patients with pyogenic. I don't know if I include the numbers here, but I think a majority were tuberculous. Basically, these patients underwent anterior column reconstruction with titanium mesh cage and posterior instrumentation, and they were assessed for residual pain, resolution of infection, kyphosis, and the state of fusion and implant. They gauged clinical outcomes using McNabb's criteria, and they said that the disease had healed if there was an absence of pain, there was bony fusion on plain films, and the biomarkers had all normalized, and patients were actually just overall feeling well. And what they found was that basically 96% of these healed uneventfully. 3 of the patients with tuberculous infections needed debridement, and 1 patient with a pyogenic infection had to have their implant removed at 12 months. But at final follow-up, all of the infections had healed, and bony fusion was seen in 94% of the patients. And obviously, I've put here that 4 of the patients had subsidence of their cage, but still a high rate of fusion in a patient population that is a difficult patient population. And so, obviously the conclusions of the study was that there was a high rate of healing with good realignment and no late recurrences of infection using titanium cages. And so basically the authors in the study say that, once you make the decision to do surgery on these patients, you should be really thinking about the thorough anterior column debridement and a stable reconstruction. And they argue that, with large defects that titanium would allow that and is effective and does not seem to be leading to any worsening of the infection. This is another study on this particular topic, and these guys are looking at whether or not you can use titanium packed with allograft or autograft, and whether there's a difference. Obviously, in infections, we generally try to use autograft, and this is starting to stray a little bit away from the metal, but it's a relevant study, and it was in our Red Journal. Basically, 36 patients with osteomyelitis were looking in a study, and basically there wasn't any implant failure in this particular population, about half, I think, who had autograft and half who had allograft. There was basically no difference therefore in the rate of infection between autograft and allograft. So they're saying that based on this study, allograft does not appear to increase the rate of recurrence placed in a titanium cage. And again, Dr. Levy spoke to this in terms of, being able to use, metal in the face of infection. I could give you a lot of studies on this. I just presented a couple. I'll put some more up here if you guys are interested in looking at them and reading them. But it's been pretty well studied at this point. Moving on from infection, another thing that we often think about, in terms of our patients is imaging that we need to perform on them. And this is a study looking at MRI and CT artifact after using different materials. I think this is, it's not necessarily, and we all have looked at images and the question of clinical relevance of all of these studies. We've all looked at images of patients with instrumentation, and generally we can get around the artifact that's created. Sometimes it's quite difficult. Certainly patients with neoplastic processes are going to have lots of imaging, and subtleties in that imaging may be meaningful. In those cases, the artifact can matter more. But basically, this study used cadaveric porcine torsos. They implanted them with various combinations of titanium, thallium, stainless steel, and they evaluated the artifact. And they had a radiologist review it. They also had an orthopedic spine surgeon. The radiologist was looking at the width of the artifact, and the orthopedic spine surgeon was looking at whether it resulted in a significant ability to clinically assess patients' clinical usefulness. And here's a grading scale that they used. And so basically, what did they find? For MRI imaging, there was a reduction in the image quality and clinical usefulness for stainless steel when compared to titanium or vitalium. Again, another reason stainless steel has fallen out of favor. And when it came to CT imaging, there's no significant difference for radiologist evaluation. And however, on surgeon evaluation, there was significant differences between metals, with vitalium and stainless steel being worse than titanium. And again, if nothing else, you begin to understand why certain implants have become more favorable and others have become less. I included this one as well. This is a study done by our own people here, Faiz Ahmad, Dr. Wang. And this one was comparing cobalt chromium versus titanium spinal instrumentation. It's done in 2013. And again, we kind of understand the design of this study. This one was analyzed by a radiologist, but basically they found that the cobalt chrome rods had more artifact than the titanium rods, but it wasn't clinically significant. In other words, it didn't interfere with the evaluation of the spinal canal. So that's what we really care about at the end of the day. The next question is, can you mix and match metals? Can you put titanium with cobalt chrome? We do, obviously. Is that okay? And this is a study that's addressing that. Rod screw constructs composed of dissimilar metals do not affect complication rates in posterior fusion surgery performed for adult spinal deformities. So you already know the conclusion of their study from the title here. Obviously we're beginning to understand that why different metals are favored over others, and titanium screws are favored for a number of reasons, but the rods obviously suffer from notch effect, as we mentioned. And so then the question is, should you be using something else for a rod? Cobalt chrome is obviously stronger, but it's more difficult to contour. So this particular author says, oh, well, you should be using titanium screws with stainless steel rods. And he did so for his deformity surgeries. And then he looked at it, he retrospectively looked at it. There were 61 patients included. All of them had obviously titanium screws. 31 had stainless steel rods, 24 had titanium rods, and 6 had cobalt chrome. He did 20 months of follow-up. And the bottom line is there was no significant difference in implant or non-implant related complications. There was a higher incidence of titanium rod fractures, which was hypothesized to be due to notch effect, but it actually was non-significant. So he says, the risk of notch effect outweighs risk of galvanic corrosion, but again, not statistically significant. This is kind of just a topic of interest that I wanted to mention. Many of you, I'm sure, have heard Dr. Wang mention this term cold welding. What is cold welding? It's actually a little bit of a controversial term in the orthopedic literature, but the the concept is not controversial, but the term cold welding is. But basically, this is a paper that talks about cold welding. Generally occurs in locking plates, and we use some locking plates. Orthopedists use them a little more. Locking plates obviously are designed to not reduce the bone towards you, so the screw locks into the plate, so you keep a fractured piece of bone where it is. But you can see similar phenomenon actually with set screws. So to understand cold welding, you need to understand what is welding. Obviously welding implies the use of heat. This is the Google definition: to join together metal pieces or parts by heating the surfaces to the point of melting using a blowtorch, electric arc, or other means, et cetera, et cetera. So cold welding obviously doesn't involve heat. So that's a phenomenon described exclusively with titanium implants, and most commonly in relation to locking plates, where you insert the screw, maybe apply too much force, maybe cross threading, but basically the screw head adheres firmly to the plate, making extraction impossible. And if you actually look at a sample, and there were a couple pictures in the study, but they didn't come across really well, so I didn't include them. But it looks like a weld. One part of the metal is indistinguishable from the other. And so, if you encounter this, which, I don't think I have yet encountered it, but, they suggest using carbide drill bits, tungsten burrs, conical extraction screws to take these cold welded screws out. So, kind of to summarize this and put this together in terms of understanding these various metals, stainless steel, as Dr. Levy mentioned, isn't really used much anymore. Was historically used a lot for deformity surgery, and this is what it's composed of. It has a higher fatigue resistance than titanium, but it also has a higher amount of corrosion than titanium. So the pros are it's actually affordable and durable and has an intermediate Young's modulus, but it suffers from issues of biofilm formation and corrosion. Higher Young's modulus than titanium can lead to increased incidence of PJK and actually more imaging artifact. Titanium is the most common metal used in spine instrumentation, and for good reason. It has lower fatigue resistance than stainless steel, but less metal artifact on imaging, less corrosion, lower rate of biofilm formation. But we do need to keep an eye on the long-term subsidence of titanium implants. Obviously, these porous titanium grafts offer promise in that regard, but not all grafts are created equal. Not all of them are designed. So you do have to understand how that modulus of elasticity plays in terms of subsidence. And in terms of titanium rods, I do think we need to be thinking about notch effect when we're bending rods. Sometimes we bend rods in 20 different ways and then put them in the patient. It's probably not a good idea. Very high likelihood those rods are going to break over time. Cobalt Chrome is relatively new to spinal instrumentation. It was formerly used in gas turbines due to its strength, and it's composed mostly of cobalt and chromium. The use of this is mostly due to the fact that it has high fatigue resistance, stiffness, and strength, and superior fusion rates as a result of that. But it is more difficult to contour, and obviously the stiffness may be a weakness along with the strength. And then I wanted to kind of just briefly, and this is more a topic of interest, include nitinol, because I think most of you, if you've heard of nitinol, have probably only seen Dr. Wang use a nitinol wire when he's doing his endoscopic cases. But nitinol is a really interesting metal that may have an increasing use in spine surgery. The name comes from the fact that it's nickel and titanium, and the null in nitinol comes from the fact that it was developed at the Naval Ordnance Laboratory. And basically, this is what's called a shape memory, or a shape memory alloy. So it has fatigue resistance and what's called super elasticity. So basically, and I'll explain this picture in a second, but basically these memory shape alloys have two distinct states, what's called the austenitic state and the martensitic state. So basically, when it's above its activation temperature, so in other words, when it's hot, it has a pre-configured shape and it will always take that shape. But when it's cold, it's malleable and can be contoured. And so this is actually in a pig here, and obviously they created a deformity that didn't exist in a pig, but it's just to demonstrate this. But basically, you place the rod in cooled, and the back is straight here, so you place the rod in straight, and as it goes in the body and warms up, it goes to its austenitic state, which is its pre-configured shape, and creates this curvature. So obviously, this is really interesting for gradual deformity correction, and is actually starting to be used for that. I wanted to show you this video just to show you how nitinol works, because it is pretty cool. And so, in this particular video, I think I turned the sound off, but this is, this guy is bending a piece of nitinol and then he's dropping it in hot water. And in this case, the pre-configured shape for nitinol is a paper clip. And so as soon as he drops it in the hot water, it turns back to that pre-configured shape. So very interesting in terms of future applications. In this talk, I think just to begin to think about future metals we can use, obviously we've only talked to, like, this is the periodic table of elements. We're really just scratching the surface. And I fully expect that we'll see different alloys moving forward with different properties. People have already done interesting and weird things like using absorbable magnesium grafts and screws and things like that. Will that be a part of the future? Probably not, but we very likely will see new iterations and versions of metals. So, what's the bottom line of this? There's a lot of different pieces of information presented here. I think there is no necessarily bottom line. It's just to understand, that when a rep comes in with a new graft, that we don't just take it and begin to put it in a patient, that we understand why we're using that graft, why it was developed, because in most cases there's a reason, right? These companies are not producing, hardware and implants without a need. And so we should understand that, and we should understand the pros and cons of what we're using. There's obviously no perfect metal, no single answer, and many times metal isn't required, but we should have a nuanced understanding of this particular topic. That's it. Thank you.
Good talk, Greg. I found the topic interesting also, and I wonder if you mentioned or if you saw that documentary, Bleeding Edge, on Netflix.
I didn't actually.
Okay, it's cool. They get into just like complications related to medical implants. It's a little bit sensationalized, patient perspective and patient testimonials and stuff. But it does talk about the cobalt chrome metal on metal hip implants and how like patients were developing dementia from that. And I was wondering myself when I was putting this together, could that happen in spine surgery? But it seems like probably just the lack of motion between the two metals is potentially a factor, why we don't see that at all.
Yeah, I think the idea that we would see toxicity from metals is probably a little bit far-fetched because, like, as you mentioned, they're dealing with mobile joints. But, would it be interesting to know that in a patient with PJK, whether their blood levels of metal ions actually increases? We're not going to make a surgical decision on that, but is it interesting? Could there be a clinical application? Maybe.
Right, if you had really sensitive measurements, probably you could maybe pick that up.
Hey, Greg, I might have missed it, but did you talk about allergies, like patient-reported allergies to metals? About probably once every 2 years, I have a patient says, I can't have this done on me because I'm allergic to metal. And then there's this series of discussions that go, you can go to an allergist and get tested for metal allergy. It's incredibly rare. I don't think I've ever seen a case, but I've certainly seen a bunch of patients say that they are allergic to metal. Is there any credence to that?
So that's that whole concept of biocompatibility. I did look at that in the literature. I found 1 or 2 case reports, nothing more than that on it. So, there wasn't a whole lot of literature on that particular topic.
Yeah, it's interesting, Alan. I run into the same problem usually after. There's the people before surgery who say I have a nickel allergy to jewelry, so your titanium alloy contains nickel in it, so I don't want that, right? And then there are the people who after surgery claim that something happened because of an allergy, right? And it's interesting because a lot of the companies will have these patches, metal patches of different types that you can put on their skin and to test them. And I've never seen somebody turn positive on those. It's very interesting. It's a very active topic of discussion, very frustrating too, because these people start to describe all kinds of problems like their fibromyalgia to the implants. And it's like the silicone breast implant thing. It's like very vague sets of symptoms, right? I don't know if you're experiencing.
I think we lost him. You there, Mike?
Oh yeah, so I'm sorry, I don't know if I came through clear. I don't know if you've had the same experience that they ask for testing and all these things. It's very bizarre, and they have all these vague complaints.
Yeah, the orthopedic guys again talk about metal hypersensitivity that they see in their patients, and most of those studies talk about localized pain. It's this non-specific localized pain at the site of their implant that they ultimately determined was a metal hypersensitivity. But yeah, I only found a couple case report. I think one case report actually in the spine literature on that.
Did you look into anything about the surface of a particular metal and how hydrophilic or how hydrophobic, how does that contribute to how it integrates with bone, or how?
Yeah, that's that. Yeah, I touched briefly on that subject. That's like a whole topic of discussion on its own. But
yeah, that gets really complicated.
Yeah, but that's the idea of the osteoconductive effect of those surfaces, and a lot of those titanium implants are being engineered to be more osteoconductive. But yeah, that's due to a complex set of properties of the surface metal.
I read about something called hyperhydrophobic or extremely hydrophobic. I don't remember what they called it, but I think generally it's hydrophilic surfaces that do better with bone.
Great, thank you.
All right, thanks, Greg. So for the topic of my talk, I decided I'll talk about unruptured aneurysms. I find it a very interesting topic. It's an area of neurosurgery that's incredibly dynamic and that we've seen a lot of growth in the past decades and few years. And it seems like every month there's new data coming out. And so hopefully this will give everyone an update on the research that's being done, as well as a historical perspective. And then I'll talk about some future directions as well. So I'm going to start with a quote. This is from Dr. Ogeman back in 1981. And I'll kind of paraphrase what he says here. This is basically an opinion piece that he wrote in the context of some studies that were written around this time, which I'll talk about. And if you kind of read what he says, I'll paraphrase. He basically says, aneurysms bigger than 7 millimeters, typically we'd recommend treating surgically. 2, he says, we don't really know about aneurysms that are smaller than 7 millimeters. We can't really make good recommendations, and we need more data on that. And 3, he says, we basically, as surgical technique and intervention becomes lower risk for aneurysms, that will help guide how we manage asymptomatic unruptured aneurysms, especially those that are less than 7 millimeters. And it's amazing to me when I read this that this is 40 years ago. And if those exact words had been published in this month's Journal of Neurosurgery, it'd be an opinion that is pretty widely accepted and agreed upon. And this is not to be depressing about our lack of progress in 40 years. And the topic of the next hour is mostly on our progress in the past 40 years. But it is to say that there's so much more that we need to study when it comes to aneurysms, and I just found this incredibly powerful. So hopefully in the course of this talk, I'll give you hope as to how the progress we've made and where we're heading. So I'll start with some historical background and some basic numbers. The prevalence of intracranial aneurysms, there's many studies out there, but basically the numbers range between 2 and 5%, depending on how the studies have been done. There's a particularly good study from Dr. Halsepian from Columbia in 1958, basically an autopsy study of over 5,000 patients. And the numbers that came out were about 2% of autopsies harbored an intracranial aneurysm. And this number is similar across other studies. There's been angiographic studies, other autopsy studies land around the same number. There's a great meta-analysis from the 90s that looked at 56,000 patients. Obviously, there may be some selection bias in a lot of these, but basically you can imagine the number between 2 and 5% of the population. As we know, aneurysm rupture is a catastrophic event. This is an interesting study from 1971 where they basically look at the natural history of ruptured aneurysms and the outcomes. It's something that we know it's bad, but this is a study that would never be done nowadays because we manage these with intervention and we manage them aggressively. But if you think about these numbers, it's striking. So they took a look at over 800 patients of subarachnoid hemorrhage with subarachnoid hemorrhage managed conservatively. In the first 72 hours, 36% mortality. And in the first 14 days, over half of the patients had died. again, we think of subarachnoid hemorrhage as a catastrophic event with high morbidity and mortality, but sometimes we don't think of the actual numbers, and and this is a study that obviously would never be possible today. The rate of rebleeding increases over the first few days, peaks around 7 days, and then tapers after 3 weeks. So basically, given the incredibly poor outcomes of a ruptured aneurysm, it's something that we often that we want to try and prevent. So I'll give a brief background as to the early natural history studies looking at unruptured aneurysms, risk of rupture and risk factors for that, because again, we're trying to, the goal is to prevent that catastrophic event of aneurysm rupture. Some of the earlier natural history studies, there's one from the early 80s, small study of 65 patients, but with good 8-year follow-up. Among the aneurysms less than 10 millimeters, they found a 0% rate of rupture, whereas for the aneurysms greater than 10 millimeters, a 28% rate of rupture. Again, a small study and not fully, a lot more work to be done at this point, but this was really an early suggestion that size is certainly important for predicting the risk of rupture for an unruptured aneurysm. Obviously, the location matters and how to assess the generalizability of the study, and we'll talk about location extensively in a little bit. A little bit later, we have the early Ishua cohort, so late 90s. They found an extremely low risk of rupture for aneurysms less than 10 millimeters, less than 1%. They split the study into two groups. Those who had a history of a prior aneurysm and those who did not. There's a higher rate for those with another aneurysm, and again, we'll dive deeper into this later. But suffice to say that extremely low for aneurysms less than 10 millimeters. They also, as part of the study, looked at surgical morbidity and mortality, and their conclusion was that the risks of intervention for these aneurysms at 1 year and even in long-term follow-up, especially for aneurysms that were small, exceeded the risk of rupture. And so they're kind of one of the points that they make is that for small aneurysms, they argue against it in many cases. Now, there's many limitations, and especially when you're not looking at when you're looking at such short follow-up, doing surgery and intervening assumes a large amount of risk at one period of time with the goal of preventing a low probability outcome over the course of many years. And so it's hard to capture that benefit, and easy to say in short-term follow-up that morbidity and mortality of intervention is higher than the risk of rupture. And we'll go into this a little deeper. But again, early suggestions that size matters and that a long-term follow-up matters as well. So moving along to the study that we've all heard about and that is quoted over and over. This is the Ishua study. It was a large study, about 1,700 unruptured aneurysms managed conservatively. They looked at 5-year cumulative rupture risk. And this is where those numbers come from that we hear all the time. The idea that aneurysms that are less than 7 millimeters and in the anterior circulation have in their study, a 0% risk of rupture, whereas over 25 millimeter aneurysms in the posterior circulation have about a 50% risk of rupture. And those are the two extremes. The major takeaways from the study were size is incredibly important. Again, increased size associated with increased rupture risk. Their conclusion was that aneurysms less than 7 millimeters in the anterior circulation, exceedingly low risk of rupture. And this is, again, one of the earlier studies that looked at aneurysm location, not just size. So in addition to size, they concluded that cavernous aneurysms were among the lowest risk. Anterior circulation aneurysms, in this study, they included anterior communicating artery, MCA, and ICA aneurysms were kind of an intermediate risk, whereas PCOM and posterior circulation aneurysms were the highest risk. So this is still really the natural history study that's most often quoted in terms of estimating rupture risk of an unruptured aneurysm. But even at this time, but since then, there's been so much progress, and that's what I'll get into. Moving along, there's a Finnish study in 2000, a smaller study, only 142 patients. But the key benefit here is that they had really long-term follow-up, so about 20 years. The differences between issue are several. So again, good long-term data, but the patient population was younger. They had fewer excluded patients, which was good. The location distribution was also, they kind of looked at rupture risk as a conglomerate. The vast majority of the aneurysms were MCA and ICA aneurysms that were generally small with an average size of 5.1. Keep in mind also that this is a Finnish study in the Finnish population, and that may not be necessarily generalizable to other geographic regions. Their major conclusions were as follows. So again, size was found to be associated with rupture risk. They found that age inversely was associated with rupture risk, and they also found that smoking was associated. In terms of their hemorrhage rates, they found it to be about 1.3% per year. Again, take it with a grain of salt in terms of the population that they're looking at, the location and the size of those aneurysms. But kind of a good easy numbers to remember: 1%, about 1% per year, 10% at 10 years, 20% at 20 years, and 30% at 30 years. And if you look at their conclusion, it's strikingly different than what Ishua kind of came to say. They say the authors conclude that such unruptured aneurysms should be surgically treated regardless of their size and of a patient's smoking status, especially in young and middle-aged adults, if this is technically possible, and if the patient's concurrent diseases are not contraindications. So they're basically saying there's a sizable rupture risk, even for small aneurysms, and that if you look at the cumulative rupture risk over long-term follow-up, it may warrant intervention, especially if the patient is a good surgical candidate. So keep this in mind as you look at the historical evolution of these studies. And then moving to some more recent studies, there's a Japanese study, over 5,000 patients, is the UCAS study. They found similar rates of rupture, around 1%. You can see in the upper right diagram, basically 1% per year that stays steady. They similarly, you can see the common themes here: increased size associated with rupture risk. As you can see in that diagram B there, really the main, the aneurysms with the substantially higher risk are those greater than 25, but it was consistent across the size groups that increased size was associated with rupture risk. They distributed location somewhat differently than Ishua. They isolated anterior communicating and posterior communicating artery aneurysms as higher risk than all of the rest. And I'll go extensively into location and why that may matter, but just keep it in the back of your head that they split it up differently than Ishua. One of the other very important findings of UCAS is that they found that the presence of a daughter sac, or an outpouching of the aneurysm sac itself, was associated with increased rupture risk. And it's really the only large natural history study to find a morphologic feature of an aneurysm to be associated with rupture risk. Again, I'll dive much deeper, but just keep it in mind that this is, in 2012, this is when that was the first one to really show that with good data.
Hey, Mike, quick question
Yeah.
before you go on. So there's no doubt that larger aneurysms have a higher risk of rupture. I mean, I think all the studies point to that. But my question is that when we look at, patients who present, many of them have aneurysms that are ruptured that are small. I mean, and then I see our vascular and endovascular surgeons use that argument to say that, well, here yesterday I saw a patient with a 5 millimeter aneurysm that ruptured, hence I'm going to take care of this next 5 millimeter aneurysm. And we've discussed the logic behind that. The piece of information I've never seen presented is that if 1,000 people are walking around with aneurysms, how many of them are in the small category? And I bet the vast majority are in the small category, and medium and large size are very underrepresented. And so does that probably impact on this phenomenon of seeing so many small aneurysms presenting?
100%. I'll dedicate probably about a quarter of this talk to that topic specifically. But absolutely, that what how many patients are walking around with small aneurysms is that is the punchline. And in a couple minutes I will get to that, and I'll dive deep into the data as well. Moving on, just one more kind of study, kind of important, looking at the natural history. As you can tell, there were several natural history studies around this time. And there's one project, the PHASES study. They looked actually at combining and pooling the analysis of these major natural history studies. In total, about 8,000 patients. They developed what they call the PHASES score, which in practice isn't used very commonly, but it's a good way to think about what what's important in estimating the rupture risk of an aneurysm. They found that age, older age was associated with 5-year rupture risk, as well as hypertension, size, which we talked about, prior subarachnoid hemorrhage, location. They found that ACA aneurysms, PCOM, and posterior were higher than MCA and ICA, and then ethnic differences as well. Finnish and Japanese background were also associated with rupture. So let's kind of step back for a second and see what these early natural history studies have told us in terms of size. At this point, most studies are using the 7 millimeter kind of level. Some use 10 millimeters, but the basic conclusion is that small aneurysms less than 7 or 10 millimeters have a significantly lower risk of rupture than larger aneurysms, and that was shown in several studies. In terms of location, these studies had very different ways of breaking down the distribution, but overall, you can think of PCOM, posterior circulation, and ACOM as higher risk than MCA, which is higher risk than ICA aneurysms. Age, different ways to break it down, but some showed the Finnish study showed an inverse correlation. Other studies showed a normal correlation. Hypertension, prior subarachnoid hemorrhage, smoking, family history, and morphology as well. So there's a lot left to be desired here, and so let's dig a little deeper into some of these topics. We'll start with family history, which is kind of an interesting one. This is a cool study that they did looking at the family history of, they basically looked at every aneurysmal subarachnoid hemorrhage case over the course of almost 20 years in a particular area, watched them over 20 years, and they found a relative risk of 4. Meaning, so basically 20% of these patients had a first-degree relative with an aneurysmal subarachnoid hemorrhage. So clearly something going on there. And there's another study showing that about 10% of cases of aneurysmal subarachnoid hemorrhage have actually a positive family history. And the number they came to was when 1 or 2 first-degree relatives has an aneurysm, there's a 9.8% risk for the patient. So this tells us that there's a risk of aneurysm in the setting of subarachnoid hemorrhage. But what about if you have a patient with an unruptured aneurysm? Does the family history mean that they actually have a higher risk of rupture than someone else? And indeed it does. There's a great paper from the Stroke Journal from a few years back showing pretty clearly that familial aneurysms have a higher rupture risk compared to sporadic aneurysms. So they matched them on a number of features, location, size, and everything. And just the presence of a family history of aneurysms, they found was associated with an increased risk of rupture compared to sporadic aneurysms. So this means if you have a patient come to clinic with a family history of aneurysms, perhaps that means that they may be higher risk than someone without a family history. Autosomal dominant polycystic kidney disease is an association that we kind of learn about back in step 1. And then, we do see all the time, we get consults from the transplant service. They do screening MRAs of the brain before transplant, and they find intracranial aneurysms quite often. It's a known association. Not only are aneurysms more common, but they've been shown to rupture earlier among these patients with autosomal dominant polycystic kidney disease. And there's also higher rates of aneurysms among men, less of a female predominance. So moving on, now we'll talk about size, exactly what Dr. Levy kind of was hitting on. So we have this number of 7 that we're kind of brainwashed with. Thanks to Ishuo, we kind of use 7 as a number, but clearly it's more complicated than 7 millimeters. We know that aneurysm growth, there's several great studies out there that show that it's not just a moment in time, but the growth of an aneurysm is associated with increased rupture risk. And this is the question Dr. Levy was asking, right? What about all the aneurysms that we see less than 7 millimeters? We see it all the time. Ruptured aneurysms, 4, 5, 6 millimeters. Does this mean that we're missing something? Does it mean Ishuo was bad? Does it mean there's something that we're missing? And even the Finnish study, 70% of the aneurysms that went on to rupture were less than 6 millimeters. So really there's something going on here. So what are some questions? So one, an obvious thought is, well, maybe after an aneurysm ruptures, maybe it's smaller, and an exceedingly small number of aneurysms that come in ruptured. Lost the light here. All right. A very few numbers of the aneurysms that have ruptured have pre-rupture imaging, and so we don't really know, or it's poorly understood whether or not yeah, you could say, oh, well, we saw this aneurysm that ruptured and was 5 millimeters, but maybe before rupture, it was bigger than 7. There's actually really good data to suggest that aneurysms do not shrink after rupture. And it's a very hard study to do. Like I said, most of the aneurysms that we see ruptured come in ruptured, and they never even knew they had an aneurysm. There's no imaging before the rupture. There was this very large multi-institution study to get enough numbers of these patients, and none of the aneurysms imaged before and after rupture in this study showed an increase in size. In fact, a decrease in size. In fact, 46% increased in size after the rupture. So this suggests that we can actually trust the post-rupture size as a proxy for the true pre-rupture size. So this means, sure, there are lots of aneurysms out there that rupture and are less than 7 millimeters. The next logical question is exactly what Dr. Levy said. What's the denominator? If there's a ton of people out there walking around with tiny aneurysms, then maybe that low risk number is correct. There's just so many out there that obviously there will be a few that come through the door with a rupture. So we have to go back to our autopsy data, there's angiographic studies, there's lots of data on the rates of the aneurysms and sizes. I'll go back to that study by Dr. Halsepian from the 50s, the autopsy study that showed the 2% rate, prevalence of aneurysms. In that study, 45% of the aneurysms were less than 6 millimeters. There's more data, angiographic data. This is a great study from 2014. 50% of the aneurysms, this was looking at CTAs, over 2,000 patients, 50%, half the aneurysms were less than 6 millimeters. Huge meta-analysis, over 50,000 patients. They found, and this was angiographic and autopsy data, 72% of aneurysms less than 6 millimeters. So we're talking about big numbers here. And if you think about that number, we said 2%, and that's on the low end, 2% of the population with an aneurysm. If we think half of those, again, being generous, half of those less than 6 millimeters, that means 1% of the population has an aneurysm less than 6 millimeters. Big numbers, and not surprising that some of them, even if the rupture risk is exceedingly low, that some of them would come in and we would see them with some sort of frequency rupture. There's actually an interesting study from Japan, the SWAV study, that specifically looked at aneurysms less than 5 millimeters, so very small. Prospective study, they looked at them for pretty good follow-up time. They found about 0.5% overall annual rupture risk. But very interestingly, if you look in their paper, among the risk factors for rupture in the small aneurysm cohort, size was still important. So size greater than 4 millimeters, even in the less than 5 millimeter cohort, mattered. So even though there's still a rupture risk of these small aneurysms, even among the small ones, bigger size matters. So what did we learn about size? Basically, small aneurysms are certainly less likely to rupture than large, but the risk is not zero. Even among the small aneurysms, larger size is still associated with a higher rupture risk. And the big kind of question mark here is, what is the denominator? We don't know, but the data that's out there, which is pretty good, suggests that over half aneurysms are small. All right, so I think we've beat that one to death. We'll move on to morphology, which I think is probably one of the most interesting parts of understanding aneurysms and where the research is today. As I mentioned, among those big natural history studies, really only the Japanese study found a significant association, and it was specifically the daughter sac, so like a focal outpouching on the aneurysm sac to be associated with rupture. But there is so much here to unpack that the natural history studies just don't get into. And it's very difficult to classify morphology, and there's different papers talk about it differently. And in order to find a statistically significant association, you really have to be specific. And I think that's probably why a lot of those early studies just didn't look at it. It also is very effort intensive. And we know that size is important, but we know that morphology is, we think that morphology matters too. It's just harder to show. Now, the fact that location and morphology have been shown to be associated with an increased rupture risk, does this suggest that there's something underneath that we're missing? We're really just looking at the tip of the iceberg here, and there may be an explanation for why, for instance, posterior communicating and anterior communicating artery aneurysms have a higher rupture risk in that Japanese study than the rest. What is unique about those locations? Maybe it has to do with the flow and the shape of the aneurysm. So that's what I'll get into now. a lot of the research recently has been into the flow dynamics. So rather than just looking at a snapshot in time, size of the aneurysm, the morphology, maybe we're missing something. Maybe there's the physical properties, the flow dynamics of blood flow through the vessel, through the parent vessel, and in the aneurysm sac. Maybe that's as important or more important than just those other numbers, which may actually be a proxy for what's going on underneath the surface. So we'll talk about a few of these. So this kind of vague, daughter sac, blebs, irregularity, a lot of papers talk about it differently, but what's the data out there? So as I said, UCAS, we know the Japanese study, daughter sac associated with increased rupture risk. There's also a great study, the ELAP study, which showed that aneurysm growth, not necessarily rupture, but we know growth is associated with rupture. They found that blebs, wall protrusions, or multiple lobes was associated with growth. So there's something about this that matters. And then there's a very recent study that was actually sent around among the residents, large study out of China. They compared ruptured cases to unruptured cases, which we'll keep in mind. They found a couple things to be associated with rupture among the ruptured aneurysms compared to the unruptured cohort. They described it as lobulations, blebs, as well as a higher aspect ratio. Interestingly, in their study, maximum diameter wasn't associated with rupture risk. So, maybe we take the results with a grain of salt. But the key limitation here is they're comparing the ruptured aneurysm, the morphology of a ruptured aneurysm, with the morphology of an unruptured aneurysm. So we know, I showed that data on size, not necessarily changing before and after rupture, but morphology may. Now talk about, this is a very interesting point about why is it that large aneurysms have a higher risk than small aneurysms? May it actually be related to morphology? This very interesting study, they looked at the change in morphology over time. And they basically found that large aneurysms, for whatever the physical properties of it, tended to have a higher risk of developing these high-risk features. So purely, keeping all things constant, just the fact that the aneurysm was larger meant it was more likely to develop these blebs or irregular outpouchings, which then we know are associated with rupture, whereas small aneurysms tend to grow more regularly for whatever reason. And maybe this is something, part of the reason why large aneurysms are at a higher risk, and certainly a lot more research needs to be done there. But it begs the question that there's something going on, again, underneath the surface. It's not just size, it's not just morphology. So some other parameters that are looked at, inflow angle, so basically the way, the direction in which the blood flows into the aneurysm. There's a good match control study that shows that it's significantly associated with ruptured cases among a bunch of different parameters. Other groups have looked at size ratio. So size ratio is basically just the ratio of the size of the aneurysm sac to the parent vessel diameter. And initially when I was looking at this, I found that it very odd to think about that and why that would matter for an aneurysm. But if you think about it, the ratio of the sac to the neck, to the parent vessel, I'm sorry, it almost means, it would almost suggest that you can imagine a large aneurysm from a large parent vessel may be equivalent or actually less, have a lower size ratio than a medium aneurysm on a small vessel. So even if the absolute number of the size of the aneurysm isn't too impressive, if it's off of a small artery, maybe that's something we should look at rather than just the number in terms of the maximum diameter of the aneurysm. There's a lot of data on this. This one study found that a size ratio greater than 2 is associated with, they did these computational calculations and found it to be associated with more complex flow, vortexes within the aneurysm sac, and low wall shear stress, which I'll talk about later is an important feature of aneurysm rupture risk. They basically, again, all computational, they basically took the same aneurysm with the same shape, everything the same, and all they did is increase the ratio of the size of the aneurysm sac to the neck. And as you can see in these diagrams, the blood flow velocity and all these other things, really including wall shear stress and the flow patterns, changed dramatically. And I'll talk a little bit later about why those numbers matter. But you can just see visually that changing nothing but the ratio of the size of the sac to the parent vessel affects blood flow in a significant way. And then other studies have shown pretty well that size ratio is associated with rupture. And so maybe this is something that we should be looking at some more. Aspect ratio is also something that's been talked about. So this is the ratio of the aneurysm dome to the neck. Again, not something that you would necessarily think of too intuitively, but several studies have shown that it matters. There's one here that showed that about 80% of ruptured aneurysms in their cohort had an aspect ratio of over 1.6, whereas 90% of the unruptured aneurysms had an aspect ratio less than 1.6. Moving on to wall shear stress. So this is an important feature of aneurysms of the aneurysm wall modeling that a lot of studies have looked at. So basically, it's a physical property dependent on the velocity and the viscosity of the blood. And if you look at where high wall shear stress occurs, it's in places where we actually see aneurysms form, right? The apex of bifurcations, constricted blood vessel regions, or the outer walls of curved vessel segments. You can think of wall shear stress like trauma to the wall, and therefore it's unsurprising that it may provoke aneurysm formation. There's been extensive research on this. They've even looked more deeply at not just wall shear stress, but what's called the oscillatory wall shear index, which shows not just a moment in time of the wall shear stress, but basically the change in the course of the cardiac cycle. And they've shown that it promotes endothelial changes, inflammatory pathways, and they actually found that higher OSI was found in ruptured aneurysms, matched ruptured aneurysms with compared to unruptured aneurysms. You can see here visually that even aneurysms in the same location and of the same size, if the OSI was higher, it was found that ruptured aneurysms had a higher OSI than matched aneurysms in the unruptured cohort. So we have all these parameters, but it's hard to kind of put it together. A lot of groups now are doing these very complex computer simulations to integrate all of these variables and model the blood flow and blood velocity in the aneurysm, and they can actually calculate the specific wall shear stress throughout the entire aneurysm wall as well as other parameters. This may help us better understand which aneurysms are more prone to rupture. So this is one kind of simple example, but with these computational models, you can actually change very specific features and see the response, the response in the blood flow, the wall shear stress, and these other things. In this example, all they kept everything same except the shape of the neck. So they changed it from a circular to an elliptical neck, and then measured all of the different features. And I just use this as one kind of concrete example, but this is basically how all of these things are being studied in terms of what features increase the wall shear stress and other aspects that increase rupture risk. So we've talked a little bit about the flow dynamics, and we talked about all these kind of physics properties, and that's, again, we're still not deep enough. We have to talk now about what that does to actually promote the formation of an aneurysm. We have associations, but we don't have mechanisms. And so I want to talk a little bit about the work that's being done on aneurysm pathogenesis. So a review of the aneurysm wall itself. There's an inner endothelial layer with the tunica intima. Outside of that is the internal elastic lamina, and then the muscular tunica media. These are the strength layers, the elastic lamina and the media. Outside of that is the adventitia. And it's very important to have, first of all, an intact endothelium and a very strong elastic lamina and media in order to allow these these arteries under high pressure to sustain that blood flow. Now, what happens in cases of a pathology of the artery wall? I'll step back and look at the different types of aneurysms. A true aneurysm maintains all three layers, but the difference is those strength layers that I talked about, the media and the elastic lamina, those are thinned for whatever reason, and I'll talk about it. Those are thinned, making the wall lose its strength, and therefore you get these outpouchings. Now, a dissecting aneurysm is very different. You basically have blood going in between the layers. You get what's called an intimal flap, and the blood escapes in between those layers. These are very high risk lesions with a high risk of growing and rupturing, and a topic of another talk. And then lastly, I'll complete the kind of overview of different types of aneurysms with the pseudoaneurysm. So this is actually where there are no wall layers, therefore that's why it's called a false aneurysm. It's basically the blood exits the artery entirely and forms a pseudoaneurysm outside of the vessel wall itself. So looking a little more deeply at the true aneurysms, which are the ones that we're talking about, as you can see here in this diagram, basically it's those strength layers that have been lost. The elastic lamina and the media, they're thinned for whatever reason. The histological features of this are degradation of those two layers and breakdown of the extracellular matrix. So, how does this happen? Well, lots of great in vivo models, lots of studies, and I'll give you kind of an overview that hopefully drives the point home. In this case, it's an in vivo dog model where they created artery bifurcations. They measured the hemodynamics and then analyzed the histology over time. And as you can see, they basically looked at the histologic process going on early on in response to this stress, this high wall shear stress from this iatrogenic bifurcation. You have this response of the wall to become hyperplastic. There's hyperplastic remodeling that precedes then a destructive process. So the inciting event drives hyperplasia, followed by a destructive process, which leads to aneurysm formation by decreasing the integrity of that wall. So as I said, you get this high wall shear stress. You think about it as trauma to the wall. The hyperplasia then leads to destructive remodeling. This involves a number of different pathways. There's elevated protease activity, there's endothelial dysfunction, as well as inflammatory changes. And again, this drives the defining feature of a true aneurysm, which is the degradation of the internal elastic lamina and that strength layer, that muscle, the smooth muscle layer in the vessel media. At this point, you have weakening of the wall and you get a bulge. And once you get a bulge, this is again from the destructive remodeling, everything kind of changes. So you get changes in the type of collagen. You get that collagen breakdown with the proteases, new collagen, which isn't as strong, and you get this aneurysm bleb. It's been shown, this is actually a figure from a paper out of our department. Endothelial dysfunction is also part of the process. That trauma to the wall causes the endothelium to initiate several inflammatory cascades, signaling pathways that drive macrophages, lymphocytes, inflammation that infiltrates the aneurysm wall, disrupts the cell junctions, drives reactive oxygen species that increases permeability, basically just wreaks havoc on the endothelium. So not only do you have breakdown of the internal elastic lamina as well as the media, the endothelium is also gone awry. Now everything changes once you have a bulge, because once that sac is created, the blood flow and the flow dynamics have been changed irreversibly. So instead of just that bifurcation with direct blood flow onto that, once you have a pouch, blood flow in the aneurysm becomes incredibly dynamic. There are areas of high wall shear stress. There's areas of low wall shear stress. If you think back to those images that I showed of the flow going through the aneurysm and those computer models, you could see how dynamic that is and how different it is than a normal blood vessel wall. In addition, in these low wall shear stress areas or these low flow areas, you can get thrombus formation. That leads down a whole nother cascade. So you get more remodeling. Thrombus is inflammatory, so that increases wall damage. And this is all within the same aneurysm sac. So you get some areas where you have thrombus and low flow, other areas where you have high flow, high wall shear stress, further driving degradation of the aneurysm sac. And in the same aneurysm, you can have the both extremes, right? High and low wall shear stress and different types of wall breakdown and different types of wall dysfunction. And that's why we see aneurysms with such bizarre shapes, and looking actually at the hemodynamic, such variable wall shear stress. Now, again, inciting event is high trauma, high wall shear stress. Once that bulge forms, then there's high and low wall shear stress. Each of those can further promote growth of the aneurysm. The high wall shear stress, just like we talked about in initiating the bulge, you get protease activity, wall breakdown, and bleb formation. For low wall shear stress, you get that thrombus, inflammation, and further breakdown. And you can actually see this image kind of shows even within the same aneurysm, different types of wall pathology. Just visually, you can see areas of thick walls, areas of very thin walls, and this irregularity is due to all of these inflammatory changes in the wall that are dependent on the changes in the flow. So how do you get to the point of rupture? Well, again, we're back to the physics of things. The wall tension depends on a number of factors, including the pressure, the radius, and the wall thickness. So you can imagine as this aneurysm grows, the radius increases, you get thinning of the wall, as I mentioned, from that trauma, that breakdown. Eventually, that trauma exceeds the ability of the wall to accommodate that intramural stress. You get failure of the wall and subsequent rupture. So the main point of going through all this is how do we use this information and predict which aneurysms are headed down this path towards rupture? So some people are strong advocates of, some groups are advocates of wall enhancement as a proxy for this process. This particular study looked at wall shear stress, low wall shear stress being associated with enhancement. So you can imagine maybe the way to differentiate those high-risk aneurysms with those high-risk flow features and wall shear profiles is to look at enhancement. And an MRI is, less invasive enough to where you can may be able to compare, even in the figures you see here, even in the same patient, same aneurysm or two different aneurysms, some enhance and some don't. And this study correlated that with low wall shear stress. It's being used more and more to kind of risk stratify patients. And a lot of groups are looking at it. This was a great prospective study of about 50 patients with unruptured aneurysms. Again, prospective. They followed them for a couple of years. And interestingly, among the aneurysms with enhancement on initial imaging, 21% grew or ruptured, whereas among the non-enhancing aneurysms, there was 0% growth or rupture. So again, a small study, not the best data, but pretty interesting, and a lot more work to be done. I know sometimes here we've been getting some of these MRIs, but the utility depends on more research. So we've added a couple features back to our big board. We're kind of working our way up, and there's really a lot of variables here, and there's so much data, and even each one of them, there's still so much doubt within them that maybe we need some better tools for integrating all these variables. So I'll talk a little bit about machine learning, and it's kind of this abstract idea that I think a lot of us talk about and hear about, but how it's actually applied to big data, especially in medicine, is not not something we talk about often. So you can think of machine learning as a more complicated way of doing statistics that basically can detect associations without being explicitly programmed. I won't pretend to be like a machine learning expert here, but for the purposes of what I'll talk about, you can think of it basically as less hypothesis driven. So it learns from data, from a training data set, detects associations that you don't necessarily explicitly tell it to look for. And that's a unique feature that's a little bit harder to do with traditional statistics, and one that's important for things like, for questions like aneurysm rupture, when there's so many variables and a lot that's not known. Maybe there's associations that we just can't pick up on as human beings. It's just too much data and too many degrees of freedom. And one other benefit is you train these algorithms on a training data set, and then you can very easily take it, plug in new numbers, and you can get a response on new data. There's different types of algorithms. I'll talk about two of the simpler ones just to kind of give you a sense of how these things work. One way, again, these are oversimplified schematics, but it's a way to think about it. One way is kind of as like a decision tree or a flow chart, where you can imagine going down a decision tree. The earlier features, the earlier branch points are the most important, right? They divide the data earlier on, whereas the ones later on are less important. So that's called a random forest model. There's also something called a support vector machine. And this basically, you could think about it as dividing data in many dimensions. In the simplest way, it would be a straight line through to some certain data points and other data points. You can then go each dimension higher, right? It's circle, then it's a plane in 3 dimensions. And then now take that and go to like 10, 12, 20, 100, 1,000. And you can see why you can pick up very complex associations that traditional statistics or just our human intuition can't figure out. This study I worked on in med school, where we actually used some of these algorithms. to look at aneurysm rupture, and we had almost 1,000 aneurysms, and we basically compared ruptured and unruptured cases retrospectively. And really, we just wanted it to be a proof of concept to see what these new tools can do and for neurosurgery and for aneurysm rupture prediction. And very interestingly, we basically found very similar findings to these big prospective natural history studies. It really recapitulated a lot of the same risk factors. You can see anterior communicating and posterior communicating artery and posterior circulation location being associated with the ruptured aneurysms, where you get the ICA and MCA aneurysms lower to the left on that diagram. Size was also associated with rupture. And so, this is far from perfect, and there's a lot more room to grow within machine learning. But this is a kind of a good early indication that, maybe these tools are valid for these types of questions in neurosurgery. We took it a step further. We thought, well, maybe aneurysm morphology, that's something that's obviously very complex. We've tried with our physics knowledge to figure out the flow dynamics and how that may affect morphology and rupture risk. But maybe machine learning can do this. And there's a whole world of what's called machine vision. And it's basically machine learning, but for visual tasks. And this has been highly developed. They have apps where you can detect, for instance, skin lesions, and it can automatically tell you that that's a melanoma or a benign lesion. So we thought maybe the same could be done for radiographic studies, and the whole field of radiology is actually being transformed by machine learning. So why not for aneurysms? Interestingly, we took over 800 manually annotated CTAs and compared unruptured and ruptured cases, and didn't find anything. We collaborated with the best and brightest at a dedicated biomedical imaging group at MIT, and nothing really substantive came out of that. And obviously, I'm not saying our study was perfect, and there's certainly probably a lot that we're missing. But I wanted to kind of share this experience because it tells us a couple of things. First of all, machine vision is very much in its infancy, and there's a lot more work that needs to be done to mature it. And also, is this just because the study wasn't perfect, or does this actually reaffirm the idea that comparing ruptured to unruptured morphology isn't valid for identifying features that are predictive of rupture, right? As I talked about, there's so few aneurysms that we see ruptured that had pre-rupture imaging. I mean, just less than 1% of the data out there is like that, probably way less than that. And so can you say that looking at the morphology of a ruptured aneurysm and comparing that to an unruptured aneurysm, can you use that to figure out features that are predictive of rupture? This negative finding may suggest that you can, and as I talked about a lot, that's not necessarily the best proxy, because morphology likely changes with the rupture event. So where are we headed? I talked a lot about what's been done and what's being done now, but where are we looking where are we going as we look into the future? We'll talk about, so again, I'll take you back to this quote from Dr. Ogeman and that point he made at the end, basically saying, as neurosurgical techniques, as anesthesia gets better, as morbidity and mortality go down, then that really fundamentally affects the decision of when and how to treat an asymptomatic unruptured aneurysm. It's all about how much risk you're willing to assume. Similarly, the Finnish study that I talked about, the same quote, right? If it's technically possible, or if the patient's concurrent diseases are not contraindication. So really the main decision point, it's a cost benefit analysis. How risky is the intervention, and how much risk are you saving the patient? So are changes in how we treat aneurysms, does this affect that decision? Sure. We know obviously surgical techniques have progressed tremendously, but in the past 10, 20 years, really endovascular treatment is what's grown, unlike really much that we've seen in neurosurgery. It started off with coiling a couple decades ago, and now there are just a myriad of devices, from the pipeline stent, the web intrasaccular device, there's pulse rider, it's just an endless array of technology, and it seems like every month there's something brand new. So how has this changed things, and does that change the decision algorithm? We see that clearly more aneurysms are being treated. You can see this steady uptrend, and this is actually old data from the early 2000s. The overall number of aneurysms being treated has gone up, but most of it's driven by endovascular treatment. As you can see here, the rates of clipping, and this is from 2004 to 2014, you have pretty steady rates of clipping for unruptured cases, and a steady increase in the rates of endovascular treatment, and same thing for ruptured cases. And again, this is still kind of old data. There's not a lot of new stuff out there. And you can imagine that since then, the last 6-7 years, those numbers have continued to drive in that direction towards endovascular treatment. And looking at this data, there's a number of studies out there. You can see increase of endovascular treatment in the early 2000s up to 28%. This is a single institution study. Looking at a national database just in 3 years, from 2011 to 2014, for unruptured aneurysms, you had a rate of 45% up to 58% of endovascular treatment. So as technology improves and endovascular therapy continues to rise in prevalence, we'll see new technology that will continue to drive aneurysm treatment towards endovascular therapy. This means that more sites, more places are able to do it. We know that for both clipping and coiling, the morbidity and mortality has decreased over the past several years. So intervening on these aneurysms, whether it's open or endovascular, has become safer. And again, this changes the decision algorithm. And you can see just overall more physicians are treating aneurysms. Endovascular is something that's very accessible even to other specialties. There may be some variability in the outcomes. You can see different morbidity and mortality from different fields, but overall you're getting increased endovascular treatment and increased physicians treating these aneurysms. So, this decision algorithm continues to evolve, and as treatment options change, as we better understand aneurysm risk, we'll kind of this field will continue to grow. So I want to compare, again, going back to Dr. Ogeman's quote, you compare that to a quote from just this year, where it basically identifying high-risk aneurysms is what's going to help us better risk stratify. That's basically exactly what was said 40 years ago. And so I really hope that the progress we've seen over the last 40 years continues over the next 40 years. And I expect to see a tremendous amount of growth in this very exciting field. So we'll see where we go, and it'll be very exciting to see.
Great job, Mike. Can you hear me?
Yep.
Yeah. So, my question is this: I'm sure you can create a formula for a threshold size of aneurysm to recommend treatment, and you could do a separate formula for endovascular and for open. And not to piss off my open vascular colleagues, we know that the risk profile, particularly in the elderly, is quite a bit higher in open treatment. So does that exist? I mean, it should be pretty simple. I mean, assuming that the risk profile was 0 for your intervention, and we're hoping to move towards that. I mean, it would make sense to treat all unruptured aneurysms if that was in fact true. But there must be a size threshold where you say this makes complete sense. I don't have that number. I don't know if you have that number.
Yeah, I mean, I think there's so many factors that go into it. We also see plenty of aneurysms that are 20 millimeters and stay and aren't ruptured. And so I think we still don't fully understand what goes into it, even though we know increased size is associated with it. Having a hard cutoff and just looking at size, I don't know if we're there yet. And even when we look at integrating a bunch of different variables, even then it's hard to kind of pin down certain cutoffs for things. So I think really kind of the take-home point is that in theory, yes, you could have, if imagining 0% risk of the intervention, you could just, you treat everyone, but maybe with assuming certain percentage risk for different populations, you could have different cutoffs. But I don't know how cut and dry, I don't know how possible it is to have that cutoff. And I also think that's what makes it kind of an art and a discussion with the patient and how much risk you're willing to assume. Are you someone who would rather just live with the thought that, maybe 1% chance every year that you drop dead with a subarachnoid hemorrhage versus assuming a certain amount of risk now at this moment and then giving yourself basically 0% risk of rupture in the future? And I think that's, I think that kind of counseling and with the patient is what is going to be needed for a long time until we get smarter.
Yeah, I agree, Mike. That was a great talk, and I think the real challenge to the counterpart of coming up with that model is poor understanding of the natural history due to flaws in the studies that we have, and the fact that most patients want to be treated, and so they fall out of or we're making a decision for them, or they're making a decision, so they fall out of natural selection studies. The UCAS Japanese study, the really important thing there is 7,000 patients initially started in the trial, and half of those patients fell out of the trial because they had aneurysm progression and they received treatment. So that's an incredible selection bias. But, I think we'll continue to improve on morbidity and mortality of treatment, and we'll continue to improve on assessment of risky aneurysms. I think the wave of the future is going to be some better imaging technology like molecular imaging, or being able to assess inflammation within aneurysm domes to predict more unstable aneurysms. And it'd be hard to believe that we won't get there in the next 40 years.
Yeah, Mike, this is Dr. Ivan, great talk. I just want to kind of echo Bobby's thoughts too. Some of the work coming out of the Barrow now that was started at UCSF with David Young, and now with this new guy, Hashimoto, has really kind of amplified this idea of the neutrophil effect and the inflammation effect to aneurysms. And I think that until we fully understand that, like Bobby was saying, it's hard to make any kind of predictive model on size or shape, because I think that's just a small percentage of the equation. But if you have somebody that has an aggressive immune status or has injury to the wall and they respond differently to the injury in the wall, it's more about how they respond to that injury more than what the size of the dome is. And I think they're just starting to understand that. And, they're coming out with these new neutrophil traps and whatnot to kind of treat aneurysms. And until we kind of really understand if that could work, it's hard to make a model system without that part of the equation. So if somebody hasn't figured out the right size in the last 75 years, it's unlikely we're going to do it without putting something else into the equation. And I think that's the inflammatory state and inflammatory response is one of the key things that we're missing.
Hey, Michael, Jacques Morcos here. Great talk. Sorry, I came in and out because I was giving a Zoom to Ohio State. I don't know if I missed it, but did you mention the significant increase in risk of bleeding when you have documented growth of an aneurysm in a given patient? There was work at UCLA done, and I don't know if it's been replicated elsewhere.
I mentioned it. I didn't go through the studies themselves, but yes, there's pretty good data to suggest that not just the snapshot in time size, but actually growth over time is associated with increased rupture. Yes.
In that study, it was 12-fold. And actually, I also remember in conjunction with what ago, and he said one day we will give anti-inflammatories to treat both carotid artery stenosis and aneurysms. So this exactly this inflammatory cascade is key. But it's interesting. Great job.